Recording. Progress.
എൻ്റെ മുത്ത ഒന്ന് വീട്ടിൽ അതൊന്നൊരു സീനല്ല. എന്നാണ് offended. സംബന്ധിച്ച് മാർക്കും സംഭവം റാങ്കിനൊന്നും അത് ഇനി ചോദിച്ചിട്ട് കാര്യമില്ല. അതുകൊണ്ട് പറഞ്ഞത് അങ്ങനൊന്നും വിചാരിക്കില്ല. I'm totally not offended. I have gone through much more shit than this. I'm a 21-year-old guy. So ആവശ്യത്തിൽ കൂടുതൽ ഷിറ്റ് ഞാൻ കേട്ടിട്ടുണ്ട്. ഇതൊന്നും ഒരു സീനുണ്ട്. എനിക്ക് ശാസം എനിക്ക് റാങ്കിനെ കുറിച്ച് സംസാരിക്കാൻ ഒരു താല്പര്യമില്ല. അപ്പൊ ഒഫൻഡഡ് ആവുന്നതല്ല. ആൻഡ് യു റിയലി വാണ്ട് ടു നോ എന്റെ റാങ്ക് എത്രയായിരുന്നു? കേരള റാങ്ക് എത്രയോ 18,000 സംതിങ് ആണ്.
ഗോവിന്ദേ
ഗുഡ് ആഫ്റ്റർനൂൺ ഓൾ. കേക്കാവോ?
മാം കേക്കാം.
കേക്കാം. മൊത്തം എത്ര പേരാണ്? 80 പേരേ ഉള്ളോ?
ഇല്ല മാം, 156 ഉണ്ട്.
156. ഓക്കെ ഓക്കെ, ഞാൻ സ്റ്റാർട്ട് ചെയ്യട്ടെ.
ആ മാം.
Okay, today my topic of presentation, today's my class is about cholesteatoma and chronic otitis media tuberculosis disease. What is chronic otitis media? Chronic otitis media is defined as a chronic inflammation of the middle ear and mastoid. That is the middle ear cleft. Inflammation, it's a chronic inflammation of the middle ear cleft which present with the recurrent episodes of ear discharge through a pre-existing tympanic membrane perforation. This is defined as the chronic otitis media. So chronic otitis media is defined as a chronic inflammation of middle ear and mastoid which present with recurrent ear discharge through a tympanic membrane perforation. Chronic otitis media, the perforation becomes permanent when its edges are epithelialized by the squamous epithelium. The chronic otitis media can be divided into chronic otitis media with cholesteatoma or without cholesteatoma. The previous classification, previously the chronic otitis media is otherwise known as chronic separative otitis media. Now the common definition is chronic otitis media. The tuberculosis disease nowadays it is called mucosal disease, and aticoantral disease is nowadays called squamous disease. The chronic separative otitis media or chronic otitis media is more common, is more prevailing in the developing countries. The type of coming to the types of chronic separative otitis media, mainly tuberculosis disease and aticoantral disease. The tuberculosis disease is otherwise called safe or benign type. It mostly involves the antero-inferior part of the middle ear cleft. And the tuberculosis disease is not associated, not usually associated with the complications. AAD, aticoantral disease, is more often associated with the complications. Coming to tuberculosis disease, coming to the etiology of the tuberculosis disease. Usually the tuberculosis disease usually occurs as a sequelae of acute otitis media. acute otitis media, which is following an exanthematous fever that leaves behind a large perforation. That is the most common sequelae associated with the tuberculous disease. Coming to other etiologies like ascending in any infection in the nose and nasopharynx. Any infection in the nose and nasopharynx can ascend through the eustachian tube and affect the middle ear. Middle ear cleft that can also cause tuberculous disease in the future. And coming to the other associated etiologies like food allergy to dust, allergy to dust, or some food items like milk, egg, fish. These all can cause to can predispose to they predispose to chronic suppurative otitis media tuberculous type. Coming to chronic suppurative otitis media is mainly divided into tuberculous disease and aticoantral disease. Coming to the difference between these two types, usually the patient presents with coming about the discharge in tuberculous disease. The patient usually presents with a profuse discharge, which is mucoid in nature and usually not foul smelling, and it is odorless. Where in case of unsafe disease or AAD, the patient usually have present with a history of scanty discharge, which is purulent in nature and foul smelling. And history also, in tuberculous disease, the patient will be having a long-standing history, and usually from the childhood onwards or in the early adulthood. In AAD disease, the history will be usually not long-lasting history. Coming to the in examination, coming in tuberculous disease, the perforation will usually be central perforation. In case of aticoantral disease, the perforation is usually attic or in marginal perforation. And granulation and granulations are most commonly seen in aticoantral disease, and it is rarely seen in tuberculous type. The polyp, coming to polyp will be pale in case of tuberculous disease, and it will be red and fleshy in the case of aticoantral or unsafe type. And cholesteatoma and complications are usually present in the case of unsafe type of disease, and it is rare in the case of tuberculous disease. And in audiogram, and coming to audiogram and hearing loss, it will be mild to moderate conductive hearing loss in case of mucosal disease, and it will be conductive or conductive and moderate conductive hearing loss or mixed hearing loss in case of the aticoantral disease or unsafe type of disease. And complications are usually associated with AAD. Coming to the pathology of the tuberculous disease, the middle ear mucosa is mainly lined by three types of epithelium. Single non-ciliated cuboidal, the single non-ciliated cuboidal epithelium, simple or ciliated cuboidal epithelium, and a single row of flattened squamous epithelium. The anterior part and the attic area is usually lined by single non-ciliated epithelium, and the rest of the middle ear cavity is lined by simple or cuboidal epithelium, and the area of attic is lined by single row of flattened epithelium or pavement epithelium. The tuberculous disease, the pathological changes that occurs in tuberculous disease is usually The pathological changes. The pathological changes that is occurring during during tuberculous disease. Okay, the pathological changes happen during CSOM is perforation of the tympanic membrane. Usually, it will be central perforation. And coming to the middle ear mucosa is usually normal, and in active case, it will be inflamed. The other associated changes occurring is polyp. The polyp will be usually the edematous middle ear mucosa is appearing as a polyp. Then there will be associated ossicular chain erosion, tympanosclerosis, and fibrosis and adhesion will also be seen associated with the other changes. The usual organism associated with CSOM are Pseudomonas aeruginosa, Proteus, E. coli, Staph, and Staph aureus. The clinical features of tubertympanic disease include ear discharge, perforation, ear discharge, which is profuse, mucoid, and non-foul smelling ear discharge. And the perforation will be usually seen. Perforation will be usually in the pars tensa, and it will be the central type of perforation. The middle ear mucosa, the perforation, the middle ear mucosa can be seen through the perforation, which will be usually in case of active disease, it will be usually red, edematous, and swollen. And if any polyp is seen associated, if the polyp can be seen protruding through the perforation. And the patient will complain of associated hearing loss, which is conductive type. And it varies in severity, but usually the severity it does not exceed 40 to 50 dB. It does not exceed 40 to 50 dB hearing loss. And sometimes the patients complains of a paradoxical effect, that is, they can hear better in the presence of discharge than when the ear is dry. This is called a round window shielding effect, which is produced by the discharge, which helps to maintain the phase differential. Which helps to maintain the phase differential is essential for hearing. Coming to the investigations, the usual investigations are examination under the microscope. Examination under we are doing examination under the microscope. We can the uses of examination under microscope. We can differentiate between whether it is a perforation or whether it is a retraction pocket. If it is a perforation, the edges of the perforation can be visualized, and if any associated discharge is there for the investigation, culture and sensitivity can be taken while doing examination at the microscope. The edges of the perforation can be visualized, and edges of the perforation, if need to be freshened, can be freshened in by doing examination under the microscope. Other investigation that need is to assess the hearing loss. Puretal audiogram is done to assess the hearing loss. Culture and sensitivity is also done culture and sensitivity is also done. Culture and sensitivity is done to assess which is done. If the patient is present with the profuse discharge, we will start antibiotic, and culture and sensitivity is also set. Culture and sensitivity is usually done to assess which antibiotic is need to be prescribed for the patient, and to assess the status of the ossicular chain, and to assess the anatomical landmark. X-ray mastoid on CT scan can also be taken. If you are suspecting any complication, or if you are planning for any surgery, HRCT temporal bone can also be done. And X-ray mastoid, we can assess the pneumatization, and pneumatization and other important anatomical landmark can also be seen in also be assessed by using X-ray mastoid. Coming to the treatment of CSOM toilet, the usual treatment we've given is regular oral toileting. The ear section, the regular ear section clearance is done. On a regular basis, we are doing ear suction clearance. Topical ear drops can be done. സോറി എന്തോ നെറ്റ്വർക്ക് ഇഷ്യൂ ഉണ്ടെന്ന് തോന്നുന്നു. ഒരു 5 മിനിറ്റ്സിൽ ഞാൻ ഇപ്പോൾ റീജോയിൻ ചെയ്യാം. ഒരു 5 മിനിറ്റ്സ്. ഇപ്പൊ പ്രസന്റേഷൻ കാണാൻ പറ്റുന്നുണ്ടോ?
കാണാം.
സോറി, ഇവിടെ നെറ്റിനും ഇതിനും കുറച്ച് ഇതായിട്ടുള്ളതാണ്. ലെറ്റ്സ് കണ്ടിന്യൂ. Investigations, examination under microscope, pure tone audiogram, culture and sensitivity, X-ray, mastoid, and CT scan. Coming to the treatment, oral toileting. Eardrops we can use topical antibiotic eardrops can be given. Topical antibiotic eardrops can be given. If it is not controlled, if the patient's complaint is not subsiding with the topical antibiotic drops, or the patient is presenting with profuse ear discharge associated with severe hearing loss, we can start systemic antibiotic. Systemic antibiotic is given for a course, and before planning for surgery, patient have at least free of discharge for a period of at least 6 weeks. Or if any associated contributory cause like adenoids or any other nasal pathologies like deviated nasal septum is there, we have to treat the contributory cause. Then we should proceed with the definitive treatment. Then we should proceed with the surgical treatment. The surgical treatment usually need is either laryngoplasty or cortical mastoidectomy with the cortical mastoidectomy. If the patient is having only mild hearing loss and only the patient's only complaint is ear discharge, or the patient is having only a middle or a moderate central perforation, we can proceed with the laryngoplasty. But the patient is having complaints of ear discharge associated with severe hearing loss, and while assessing the hearing ossicular status, if the patient is having ossicular erosion, then we will proceed with the and if there is any during our investigation, if there is any clue that the investigations the disease progress to mastoid also, we will proceed with the cortical mastoidectomy. And reconstructive surgery is definitely after cortical mastoidectomy. Here reconstruction or laryngoplasty, here reconstruction can be done as the second procedure. Coming to chronic otitis media with the cholesteatoma. The term cholesteatoma was first described by Muller in 1838. Cholesteatoma is defined as a mass formed by keratinizing squamous epithelium in the middle ear or mastoid, covered by subepithelial connective tissue and by a progressive accumulation of keratin debris with or without surrounding inflammatory reaction. Coming to the pathological anatomy of the cholesteatoma, cholesteatoma matrix consists of three parts. First, a dead anucleate keratin squamous and a matrix composed of fully differentiated squamous epithelium resting on a connective tissue stroma. The deeper layers of the matrix is laid on by the underlying, growing into the underlying connective tissue. Coming to the origin of the cholesteatoma, several theories has been proposed, that like congenital cell rest theory, Wittmann's theory, Rudy's theory, Haberman's theory, and the Sades theory. The cholesteatoma can be classified into congenital cholesteatoma and acquired cholesteatoma. Congenital cholesteatoma. Congenital cholesteatoma usually arises from an embryonic epidermal cell rise in the middle ear cleft or the temporal bone. Congenital cholesteatoma is defined as an expanding cystic mass with keratinizing squamous epithelium located medial to the tympanic membrane, assumed to be present at birth or diagnosed during infancy or early childhood, with no prior history of otorrhea, perforation, or previous surgery. This is the definition of the congenital cholesteatoma. Coming to the etiology, it is a persistence of the epidermal cell rest in the anterior epitympana. Normally, the anterior epitympana usually involutes by 33 weeks. If it persists, it can lead to congenital cholesteatoma. It can also be seen in the posterior middle ear or petrous apex. The usual sites of congenital cholesteatoma is middle ear, petrous apex, and the cerebellopontine angle. And based on the site involved, the symptomatology can also be different. Usually, the middle ear congenital cholesteatoma present as a white band behind an intact tympanic membrane and can cause conductive hearing loss. In usual situations, it may sometimes be discovered during a routine examination. It can be either present during childhood or during early adulthood. It may also spontaneously rupture through the tympanic membrane and can be present as a discharging ear. Coming to the acquired cholesteatoma, acquired cholesteatoma can again be divided into primary acquired cholesteatoma and or secondary acquired cholesteatoma. Primary acquired cholesteatoma is called primary as there is no previous history of any previous otitic media or any pre-existing perforation. Coming to the theories of the primary acquired cholesteatoma, it is the retraction theory, which is a widely accepted theory, the metaplasia theory, basal hyperplasia theory or papillary ingrowth theory, and the immigration theory. The invagination theory of Pelasgian, the retraction theory or invagination theory, it was proposed by Bezold and it is expanded by Wittmann. Here, the eustachian tube dysfunction, if the patient is having any nasal pathology, it can lead to eustachian tube dysfunction. The eustachian tube dysfunction can in turn lead to hyperventilation and negative middle ear pressure, which will lead to the invagination of the tympanic membrane. The squamous epithelium in the pars flaccida or pars tensa can no longer migrate it will lead to invagination of the tympanic membrane, and from the invaginated tympanic membrane, the squamous epithelium can no longer migrate and self-plate. This leads to accumulation of the keratin debris, and build up keratin debris will build up there. This is known as the retraction theory or invagination theory, which is proposed by Bezold. Coming to the next theory, which is the basal cell hyperplasia theory. Basal cell hyperplasia theory is suggested by Lang and it's supported by Rudy. Here, It is the proliferating epithelial cells invade the lamina propria through a basal membrane. There will be microperforations in the basal membrane, and through this microperforation, the proliferating epithelial cells invade the lamina propria through the basal membrane disruptions. This will lead to microcholestyatoma, which will enlarge and later perforate the tympanic membrane. The next theory is the squamous metaplasia theory. It is theorized by Wendt and is supported by Seitz. Here, the simple squamous or cuboidal epithelium or middle ear cleft undergo metaplasia to the keratinizing epithelium. The debris will accumulate inward and it will also ultimately lead to the perforation of the tympanic membrane. The final theory is epithelial invasion theory or immigration theory. Here, the keratinizing squamous epithelium from the surface of the tympanic membrane invade the middle ear through a pre-existing perforation in the tympanic membrane. It is theorized by Bezold and Haberman. There is another theory which is that is the implantation theory. This is the implantation theory of the squamous epithelium into the pneumatized portion of the temporal bone following a trauma or surgery. It can usually lead to the secondary acquired cholestyatoma. In secondary acquired cholestyatoma, there will be usually a pre-existing perforation in the pars densa, and this is often associated with a postero-superior marginal perforation or sometimes with a large central perforation. The cholestyatoma is usually associated with the bone erosion. The bone erosion in cholestyatoma is usually due to pressure necrosis or is proposed by pressure necrosis theory or enzymatic theory. Due to the pressure of the cholestyatoma, it will activate the monocytes, and this will lead to monocytes, and this will release active metabolites. And these metabolites can lead to that causes increased bone erosion, and this will lead to the bone necrosis. Another theory, which is the enzymatic theory, that is the cholestyatoma matrix can in turn release several active enzymes like collagenase and acid phosphatase. These can in turn lead to bone resorption. This is the enzymatic theory. These are the two theories that is proposed by that for the bone erosion in cholestyatoma, that is the pressure necrosis theory and the enzymatic theory.